right, good afternoon, and thank you for joining us for today's webinar entitled Understanding Pneumococcal Vaccinations. All registered participants should have received a copy of today's presentation via email. My name is Heather Ridge, and I am today's moderator, and we do appreciate your patience. This presentation is provided by the North Carolina Statewide Program for Infection Control and Epidemiology, also known as SPICE, and funded by the CDC Infection Control Assessment and Response, or ICAR grant. The North Carolina initiative was a 3-year collaborative effort between the North Carolina Department of Public Health and SPICE. Infection control program evaluations were provided to 113 long-term care facilities across the state. Today's topic was identified as one of our gaps during our long-term care assessments. To learn more about this grant, please visit our website at spice.unc.edu. All lines have been muted for the presentation. If you are joining us via phone, please mute your phones now and do not place the call on hold. Questions will be addressed at the end of the presentation. You may type a question in the chat box by hovering over the icon at the bottom of your screen, or unmute your phone during the question and answer session at the end of the presentation. This webinar is being recorded and will be available on the SPICE website along with the presentation slides. A brief evaluation will be sent out to all registered participants for program feedback. Upon completion of the evaluation, your certificate of completion will be available. 1 hour of continuing education credit is provided for this webinar. Today, we will be using some audience polling software during the presentation. So I've already announced it earlier, but also it's available in your chat box, and I see some of you are already doing it. If you have a smartphone and would like to participate, please use the information on your screen, and you can let us know what you think. So at this time, please do. Good, we got 4 people, so we're getting rolled. We're just gonna roll through, just kind of asking how many people are on the webinar today. And this is kind of if you've got people with you. All right, very good. So save that for later, everybody. All right, today's speaker is Robert Marty Cooney. He is an infection preventionist and the infection control officer for the UNC Rex Healthcare in Raleigh, North Carolina. Marty recently completed his NPH practicum at UNC SPICE for his master's in public health from the University of New England. Marty has also earned a master's in entrepreneurship from Western Carolina University and has his bachelor's in nursing from the University of Central Florida. He is board certified in infection prevention and control and has recently completed a 3-year term as a board member for the North Carolina APIC chapter. His main professional interests involve preventing health-associated infections of all types and outbreak control. Marty, thanks for joining us today, and we look forward to your presentation.
Thank you. So good afternoon, everyone. Thank you very much for your patience. I hope everyone's having a wonderful summer. We're going to get started here of understanding pneumococcal vaccinations. So real quick for disclosures, I do not have any financial disclosures. I am, as she said, work at University of North Carolina's Rex Healthcare Hospital in Raleigh, North Carolina, and my coursework in my practicum program you're fixing to see now with the pneumococcal vaccinations. The objectives for everyone, you should be able to describe the causative agent for the pneumococcus associated diseases, identify the groups at highest risk for pneumococcal disease, understand for whom pneumococcal immunization is recommended, and then locate resources relevant to the current pneumococcal immunization practice. So pneumococcal disease. This is caused by the bacterium Streptococcus pneumoniae. To date, there are 92 serotypes that have been documented, so it's not just one single type that's out there. Most of the S. pneumoniae series types have been shown to cause serious disease. So this is a picture of it. So this comes from the Center for Disease Control and Prevention from an electron microscope there. This particular first key facts that's highlighted in red, whenever we did the pre-polling software for folks, many people thought that it was only pneumonia that the vaccinations were able to help, but that's not correct. The pneumococcal infections, they can range more than just pneumonia. You can have ear and sinus, you can have meningitis and bloodstream infections that can be quite severe. So what does this actually mean? For example, for severity, 1 out of 20 folks who get pneumonia related to pneumococcal will die from it. 1 out of 5 that get meningitis or bloodstream related to pneumococcal disease would die from it. So it's quite serious, especially when you get into the elderly population. It is common in young children, but like I said, the serious illness and death is predominantly in the adults, older adults. There are 2 kinds of vaccines that can help prevent this type of disease. So the transmission of this, it's very common in the upper respiratory tract. And so people can be colonized with this, and then they cough, they sneeze, they spread this tiny particulates out into the air for other folks to unfortunately be exposed to. But as you see, 5 to 90% of healthy persons are carriers that do not have symptoms of it. The duration of carriage can vary greatly and is generally longer in children than adults. And we've seen this other types of things too. S. pneumoniae, transmission can occur, as we talked, is it spread into the air. So, one thing that we've seen in healthcare, if somebody is coughing up and sneezing and hacking up into the air, standard precautions for folks. You don't have to just be right there in the room and not get a mask. It's okay for you to put on a mask and when you have somebody coughing stuff up. So it's just a little side note there for PPE. So how it happens, of course, this bacterium can invade the body and cause serious illness. And especially if you have folks who have immunocompromising conditions, that can definitely make them more susceptible. You can look at the 3 major ones here: pneumonia, bacteremia, and pneumococcal. So very deadly stuff, as we talked about mortality earlier, with the 1 in 20 pneumonia, and then, of course, the 1 out of 5 with the other 2. Risk for death. So pneumonia risk, if you look at pneumonia itself, just pneumonia, the common clinical presentation, it accounts for up to 36% of the adult community-acquired pneumonia. So a lot of times this is not something that's acquired in the hospital. It can be out and about in the communities and spread. People are more likely to get pneumonia, not surprisingly, if they smoke. And diabetes, heart disease, other conditions can easily increase that risk too. Individuals can lower their chances of getting pneumonia by taking care of their medical problems, of course. Have to throw in stop smoking or vaping, or however you want to talk about that today, and have healthy lungs to help prevent that from happening. And of course, getting vaccinated. This interesting picture here in pink, this is something that kind of got me started off on this little project, because in North Carolina, the North Carolina Quality Center has this posted on their website where they get their data from CMS and tally things up. And it talks about North Carolina being ranked 49th out of 50th of 50 states for its pneumonia mortality rate. That is awful. And when I was sitting at a meeting and I heard somebody say we were 49th out of 50th, that really bugged me. And I said, you know what, we can do better than that. And so that's kind of why we wanted to really look at this particular project and help people understand the importance of vaccination. And of course, if you look further down, and in other states, there's people on this call from many other states. So I don't know as all your state statistics, but you could easily dig and find that out. A lot of stuff, is through your local health departments, and they post things. But anyway, more than half of all North Carolina hospitals are above the national benchmark for the 30-day pneumonia readmission rate. So, you get somebody better, then they turn around, get pneumonia, and then they come right back in to get readmitted or something. So they bounce around back and forth from either home or nursing homes back into the acute care setting. And then, of course, you get other risks and other factors of different diseases and things. C. diff and other type things you got to worry about. So anyway, if you look here also too, they do what we talked about. Pneumonia is most often acquired in the community outside of the hospital setting. Because I've heard people say, well, I don't want to go to the hospital and get pneumonia. Reality is you can get pneumonia outside the hospital. So when you look at from pneumonia, we're going to go to bacteremia. And the risk of that, there's more than 12,000 cases of pneumococcal bacteremia that occur each year without pneumonia. So you can easily get something without pneumonia. And this is one of them. So the overall case fatality rate is about 20%, can be high 60% among elderly patients. So we see this is very, very important. We try to prevent with vaccination to help these folks not get this. Symptoms of pneumococcal bacteremia may include fever, chills, and of course, even cognitive affect their cognitive abilities. And sometimes it's hard to detect in an elderly population. So unless you're really working close with them and you understand, very difficult. There's also the meningitis risk. Okay, so pneumococcal causes over 50% of all cases of the bacterial meningitis in the United States. So that's around 3,000 to 6,000 cases per year. But remember, whoever gets this, 1 out of 5 is going to die. So that's a very big, serious thing. We definitely don't want to spread this stuff. So you can see some of the patients with meningitis will have pneumonia, some won't. And then it talks about the case fatality rate, and it's just higher among adults than the kids. So going into the vaccines. So this is the most important way that we can do to try to help prevent these folks, because people will cough, they will sneeze, they will be in close proximity to others. Okay, so the ACIP, the CDC's Advisory Committee on Immunization Practices, they do recommend pneumococcal vaccine for all adults 65 years and old or older, and also for some adults that are younger than 65 who have had certain chronic health conditions. And for the purpose of this talk today, it's really focusing on adults, so not kids. So if you look at one particular study in 2017, it talked about the recommendations, and it talked about the guidance for nursing homes and residents. And it point blank tells you pneumococcal vaccination is a national health priority in older adults in the long-term care settings. We can provide amazing care to folks, but if we're not vaccinating them from common community spread organisms, we're really failing at doing our part. And then of course you can't have high mortalities associated with that. So as far as for screening in the elderly population, I wanted to put this particular slide in here because, I've seen many times when, they get a doctor's order and, give this shot. It's not as simple sometimes for folks just to walk in and give a shot. There are challenges, we hinted about the cognitive abilities earlier, but there's also challenges to health records. You don't know if they already had the shot, or you have to really kind of do a little digging to find that out. But if you look at a 2018 study, one size does not fit all, and that's from an Australian Journal of Aging. And this is really important because there are these additional barriers with this population. We should always try to have respectful communication, and then a support for individual needs and preferences in the elderly population. They may not, they may have some challenges that we need to really sit down and have time to communicate. And a lot of times, whether we're in nursing homes or hospitals, wherever we work, there's just not too much time. So time can, we never want to just completely rush and these type of things. So we always have to show respect to the others and patients. So the vaccine types themselves, there are 2 different kinds available in the United States. There's a conjugate, which is the 13, or there's the polysaccharide, which is the 23. So these 2 different ones, they do help with different type of serotypes that we talked about earlier. Okay, but the key thing about these is the timing, of course. But we'll get into that in a minute. So here's a picture of the conjugate, the 13, and the polysaccharide, the 23. So before you give a shot, this is kind of nursing 101 type things, but who should not give these vaccines? You got to make sure, of course, we're screening because not everybody should get them. And we're going to talk about that here. So pregnancy, you say, well, Marty, this is a nursing home, but there are long-term care facilities that do have rehab units and people that potentially could be pregnant too. So if it's a case you have somebody pregnant, you definitely would have wanted them to have the pneumococcal vaccination prior if that was indicated, and you would definitely want to check with their OB before you would go ahead and do anything else, because these particular products have not been studied in pregnancy at this time. So it's not something that we would just push. And you definitely want to check with the OB first and look at whether the risk outweigh the rewards of that. So allergies, of course, always a big deal. If somebody's ever had a previous dose of either one, whatever, and they've had a reaction, of course, that would be a big red warning flag. Also, if they've had a Tdap and diphtheria, if they had a diphtheria toxin reaction, then they would not want to get the 13 series, the PCV13. This particular slide is an interesting one because I've seen this many times. You definitely want to talk to the provider because there are folks who they've came into a health facility, they've had a cold, and they say, well, I'm just getting over a cold, and so I don't want a vaccine. And this is like your only opportunity to give them this vaccine. Well, that would be something that if they had a mild illness, it's still okay to give the vaccine. If they're in the convalescent phase of an acute illness, which means that they're getting better, okay? They've already taken they have antibiotics and they're just on the road to recovery. And they're not moderately or severely ill. For an example, in acute care for the hospitals on here, if you had a patient who was in the ICU, they just got admitted, that would probably not be the best time. But as they're leaving the ICU and they're definitely on the road to recovery, that'd be a different ballgame. And we've talked to many physicians that feel strongly one way or the other. So it's always good to get the provider's input on this. So the vaccine information statements, the VIS, this piece of paper, okay, this is very important. I've seen many people give flu shots and other vaccines and not offer this. This is a federal law that we should be offering this vaccine statement and let them take a look at it and decide if this is right for them. It's very important. We don't want to dictate somebody's healthcare. It's part of their body and their choice too. So we want to make sure we're always considering that. And this is what it looks like. So if you go online and you pull this up, print it, you're going to see some key things like why get vaccinated. Okay, so like a nurse or a doctor or somebody can easily hand this to a resident or a family member, and they can look this over. You know, it talks about the vaccine, talks about who should not get it, and then of course the risk. And if you turn it over on the very back page, it'll talk about what about reactions and what to look for things. But then there's also this National Vaccine Inquiry Compensation Program for somebody who did get injured. It's very, 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 very rare. Okay, but just in case, it's always good that we have that. We've given that to them. Very important. And part of the questions in the pre-survey was, when do you give this? Well, this would be before you would actually give the shot. So. Where you can find that information for the PCV13 vaccine conjugate is right there at the top. So these slides will be available. I think they were already sent out to most of you, and then they'll also be posted later on the website. The PPSV23 vaccine, you can see where that's found. But let's say you have a Spanish or Portuguese, you have Chinese type of whatever resident, somebody who doesn't speak English, you can go to that website at the bottom there, and you can print in other different languages. So I think that's very good, not just for this, but other vaccines too. So we talked about giving this piece of paper before the dose, okay? Give them the opportunity to read and ask questions. Like I said, it's very important with the vaccine. And document, this is just a tip right here for you. So how do you know that it was done? Well, you could say, well, I do it every time, or that may not really fly when you can easily document it in their health record there that you provided the VIS, the addition date of the VIS. So this way there'd be no questions. So vaccine administration in adults. So the PCV13 is a 0.5 ml dose, and of course you'd use the appropriate needle for that. And the preferred site would be the deltoid muscle there at the top, and then the PSV23. It's administered, same thing, 0.5 ml dose, but it can go intramuscular route or the subcutaneous route. So for the IM injection, just like the PCV13, you would use the appropriate needle, put it in the deltoid. But for the subcutaneous, you could use the 5/8 inch 2325 gauge needle, and you can put that right back, if you look at the picture at the bottom from the CDC, into the posterior triceps area, the upper arm. So indications for vaccinations, wanted to put this in here too. Do not administer both of these shots at the same time. I was at a meeting when somebody brought that up, that they thought they could do that. You cannot do that. That would not be appropriate. We'll go into timing here in a little bit, and we'll talk about that later. It all depends on medical status, age, pneumococcal vaccination history, lots of other things. So. So the timing, here is a big slide right here, y'all. Where I found the easiest, and I've sat down with our hospital epidemiology and we've looked at lots of algorithms. There's lots of data out here on this because it's very confusing to lots of people. 50% of you found that this getting the shots are not too big of a deal. 50% found that it was a very big deal and very confusing. So we're going to try to help you out here. And this particular slide that's coming up, I got this from this web page right here. So definitely a good resource alert. Okay. So the very first, when you go to that particular web page, it'll have algorithms and things. And if you just look at the basic vaccine timing for adults that are 65 and older, if you look at the very bottom, you see the PBC13 in the little blue box here. So you can see once you give that shot, you wait a year for most of your adults, and then you're going to go give the 23rd when it's time a year later. But there are a time that you'd have to wait 8 weeks and give it sooner. The 23rd, whenever you have certain medical conditions. And like I said, there's a chart that's coming that'll really simplify this for you. But sometimes you may have folks who have already had the 23. So what do you do? If you look at the box to the right there, the bottom, they've already got the 23. Well, then you'd wait at least a year and you would give the PCV 13. Where it becomes a little easier for me to understand, and I've shown you all the algorithms on the pre-surveys and things like that. Like I said, half it was kind of confusing because they go into lots of different scenarios, but the easiest is this chart right here. So if it was me, I would definitely print a color copy of this particular slide, and this will really sum it up, because if you go to the very top left-hand corner, so if you look at medical indication, okay, so you go right across in the green and you go across, when is it recommended? Well, the PCV13 is recommended at 65 years of age. Okay, so then you give it 1 year later for the PPS 23. Okay, that's just for normal, everyday, healthy people. But let's say you have somebody, alcoholics, liver disease, lung disease, cigarette smokers, diabetes, things like that. You go down to the next, like, lighter shade pink column. Okay, then you would go ahead and give the 23 first. Okay, this would be before they're 65. So sometime between 19 years old and 64, they would get the PPS 23. Then later, when they're turned 65, they would get the PCV 13. Okay, so that's how that would happen. And then for if you go down to cochlear, there's a couple other little things. If you have a CSF leak or cochlear implant, hopefully you don't have too many of those, but if you did, then you would go down to that column and you can see, give the 13 first, and then after 8 weeks you would give the 23. Then there would be no revaccination right then until you get to 65. Okay, so now let's go into the bottom, folks, which are these last two columns all fall in the same thing here, from this problems with spleen or sickle cell or renal failure, HIV, leukemias, things like that. Okay, so if you have a patient 19 to 64, then they would get a PCV 13. Okay, 8 weeks later, they would get the 23. And then 5 years after that first dose of 23, they would get another 23. Okay, and then since they've already got the PCV 13 earlier, they wouldn't need that again. Then of course at 65, they would get another of the 23. So if you look at your patient now, who comes in, and you look at the criteria, you can go over this chart with your provider. You can look at this, and of course, this particular one just was so much easier for us to understand than all the different algorithms. But you can take a look at what's on that web page and see for yourself. So once you give this shot, of course, you don't just give it and that's it. You make sure you look for adverse reactions, and they can commonly occur within 48 hours. They can last for a little bit and then swelling go down, redness, pain, arrhythmia. But the one you got to really kind of watch out sometimes is a serious allergic reaction, which would be a medical emergency. So if somebody had an anaphylactic reaction, it's going to happen pretty quickly after vaccination of this. Okay, so they're going to need to know, of course, what to do in your facility, whether it's called 911, of course, and go on from there. Okay. So vaccine storage and handling, we're talking about vaccines. I thought this is good to put in here. Vaccines can't just be stored up on a shelf with these particular ones. They're going to have to be refrigerated. Some of y'all, you got to look at it. You may not know this or not. We do lots of inspections when we go into facilities. I've seen people try to store vaccines like flu shots and other type of vaccines in like the doors of refrigerators. That would not be appropriate because the door opens up to the air, can get a lot warmer, and just not as stable for a vaccine. You want to put that in the back of the fridge. If you have a little dorm type freezer, that's not a good freezer for vaccines. That where you look at the small little one that freezes over and things like that. So vaccines, in order for them to really be effective, they have to be stored in the right conditions. Okay, so you definitely want to leave it in the original packaging. And then you can see here between 36F and 46F, you would keep those on a refrigeration unit, okay? Don't use the vaccine if it's beyond the expiration date. I've seen that before where people let them expire sometimes, so you definitely don't want to do that. Do not freeze it, okay? If there's something to it that just doesn't seem right or whatever, of course, I would not recommend giving. Then, of course, you would isolate that, mark do not use, and consult with a vaccine manufacturer or your state local immunization program for guidance, where you have to go from there. So disposals, you need to discard the vials, syringes. It's according to your facility how you do it, but this is a common thing as you'd see the sharp box there. Of course, it must be secure, puncture resistant, labeled. I have seen these things. I was recently in a nursing home, and I've seen these things unsecured. So you always have to have them secure. That means you have to put them on a wall, or they're mounted to a wall, or they're in a container so they just don't spill over and the needles come out and stick people. Very important. So you always have to have your sharp box secure. This is a really big infection control type risk. So now we're at the actual testing and test your knowledge section of the presentation. And so, like I said, if you don't have that one chart in front of you, it's okay. You may be able to answer these right from your own knowledge of what you just learned or from your previous knowledge, but we can see exactly where you're at. We can see exactly where everyone's at. So if y'all log on like they mentioned earlier here for you, then you can answer some of these questions here. We can see how many people are responding and how many we can get right. So if you look at the very first one, I don't know how to do that. I can't read that part. All right, so the first one, which vaccine is indicated for a healthy 60-year-old man who smokes cigarettes? What do you think? So A, B, C, or D? Do you give the PCV 13, the PPSV 23, or both of them, or neither vaccine? So a 60-year-old who smokes cigarettes, what do you think? We've got about 13 people who's polled. Okay, so we'll see the first one. Here's what we got. So several people have said the 23, 50% of you. Okay, a couple mix for the other ones. Okay, nobody said D. Okay, all right, so the answer, you're going to give the 23. So it's recommended for the adults 19 through 64 of age who smoke cigarettes. You would only give the 13 if the man was immunocompromised, something with spleen, sickle cell, cochlear implants, things like that. So let's go to the next question. Which vaccine is indicated for a 19-year-old woman with symptomatic HIV who has never received a pneumococcal vaccination? So you have somebody 19 years old, never received a vaccine from pneumococcal, has HIV. What would you choose? What would you pick? Give a couple more seconds for you to chime in here. We've got a lot more participation on this question. Very good, very good. All right, here we go. So this is what we see. Many people picking PCV 13. Some people are picking both. All right, so it is both. And if you look, PCV 13 is recommended for persons of any age with HIV infection. The 23 should be administered 8 weeks or more after the PCV 13. Okay, so go to the next question. So which vaccine is indicated now for a 38-year-old woman who received a cochlear implant and a dose of the 23 at 36 years of age. So they've already received 1 dose of the 23. They have a cochlear implant. This one here, I think you can get. So let's see. Lots of people, very nice. So let's show where everybody's at right now. Oh, very nice, very nice. All right, so you're correct. A lot of you, a single dose of PCV13 should be administered now, since more than a year's passed since the 23. So very good, very good. All right, so which vaccine is indicated for a 28-year-old woman who has been diagnosed with breast cancer and will be undergoing surgery following by radiation chemotherapy? Hopefully, we never have this happen, but unfortunately it does. So a 28-year-old breast cancer chemo radiation coming. Okay, so which one is it? A, B, C, or D? All right, so this one's kind of, you got a little bit, yeah, everybody's hovering around 30% over here, 32, 32, 27. This one's a tricky one. So both of them would be given, okay? They're recommended for adults 19, of course, to 64 with immunocompromising conditions, including those resulting from cancer and the chemotherapy, okay? All right, so I think this is the last one here. Which vaccine is indicated for a healthy 66-year-old man? So healthy 66-year-old, what should we give him? Hasn't had anything else. Last question. Let's see where everybody's at. Oh, very good. Very good. All right. Yes, that's correct. We got that one very well. Both PCV13 and the 23 recommended for healthy adults 65 years and older. And like I said, we'll probably see a lot of these, but you could have other situations where you did see the smokers and diabetes and things like that. So I definitely want to thank you very much for your participation today and for listening in. I think that this is it can be a little tricky. You'll see a lot of you did very, very well on your questions, but I do definitely strongly suggest that you take another look at that colorful little display from the CDC that they had going over that we talked about earlier, because that particular chart, if you have it printed in color, I think if you would have retaken the exam, we probably all could have got 100 on that. So very good. Nice job. And thank you very much for your time.
Thank you, Marty. At this time, we'd like to take some questions from the audience. If you can unmute your line if you need to, or you can go into the chat box. We've already had a couple of questions that came through, a lot of conversation about lack of communication in the outpatient world and which pneumonia vaccine did they get, and just again, how do we communicate that? And that's just an obstacle I think we all face on that piece.
And also to talk a little more on that. Yes, there's times that you're not going to know whether they give it, and one question would be, is it safe if you did not know if they've had it or not to go ahead and get it? And it is safe. That's okay. If they've got a vaccine previously of the 23 and you don't know it, and they did get another one, it's not that it's going to cause any harm. The only part that could possibly happen really from this would be is it may be a little less effective or something like that. So like I said, it's not that it's going to hurt somebody, but it could be just a little less effective.
So another question that came up was about the North Carolina DHHS, what is required by them? Basically, they're going to let you know you need to follow, CMS wants you to follow what CDC says, and to at least offer it annually if they haven't already taken it. See other questions out there? Any other questions we don't have any other active questions out there?
And if some come up, you can email those to Amy Powell up here at Spice, and we can definitely get back to you on that. And thank you very much.
What do we do when they don't know which one they got? That was our question that just came in.
Right, and you'll see that under those algorithms we were talking about on that CDC webpage, that if you don't know, it's okay that they would go ahead and give as a recommended schedule, because that can easily happen. People can be confused. There's many times people thought they got a pneumococcal vaccination and they got a flu shot, or vice versa. It could have happened that way. And like I said, it's not going to cause harm. The important thing that people are covered when they're supposed to be covered, and help prevent acquiring pneumococcal type disease. So there's another question talking about, it's been 5 years or more since Pneumovax 23. Is it okay to give a 13 for a few years after? So you would give the 13 when it's indicated. That's not something that you're going to give repeat doses there. You're going to give it when it's indicated. Now the 23 is the one that you would actually have a chance to have that repeat dose. So that's when you look at that chart that we talked about earlier from the CDC. It'll talk about that, where it goes over to the last columns, and it will say, if not given previously a 13, then you would go ahead and give when after they were 65.
Great questions, everyone. All right. Well, we want to thank everybody for joining us today. And just remember, a brief evaluation will be sent out via email to all registered attendees. And once the evaluation is completed, you'll be able to print or save your certificate of completion with 1 hour of continuing education credit. Now, if you're watching in a group, please share the evaluation link so they too can obtain their certificate. We appreciate you sharing your feedback. The presentation will be available on our SPICE website within 1 to 2 weeks. Our hopes are that you'll continue growing your infection control program and providing safe care to your residents. The slides are on our website, and they were in the email that I sent out. And when I send the eval, I will send you the link that gives you access to the recording once it's posted, and the slides. So thank you once again, and have a great day. Bye, everyone.
Bye-bye. Thank you.